hiding in the heat on behalf of Medicine 3. Presenting Mrs. S, a 31-year-old lady who is a primi gravida who presented to us at 15 weeks of gestation. Her presenting complaints were fever for 3 days and altered sensorium for 3 days. The fever was high grade, there were no chills or rigors, and it was intermittent. The altered sensorium was irrelevant speech, and she was not oriented to place or person. She was a primi at 15 weeks. She had persistent vomiting for 2 months and poor oral intake. She was taken to a local hospital, diagnosed to have hyperemesis gravidarum, but she did not have any medication improvement with medication. In the emergency, when she presented to the emergency department, her respiratory rate was 44 per minute, her BP was 80/60, her pulse rate was 202, and her core temperature was 109.2. On examination, she was in respiratory distress, lying down in bed, emaciated, agitated, and she had pallor. Her heart rate was 202. She was using accessory muscles for respiration. Her respiratory rate was 44, and she was started on injection noradrenaline 10 micrograms per minute and shifted to MHDU. The differentials considered at that point of time was a heat-related illness, a sepsis secondary to a urinary or a respiratory infection, and altered sensorium probably due to severe malnutrition resulting in a Wernicke's encephalopathy. In MHDU, she was started on cooling measures, injection meropenem 1 gram IV QATH and injection thiamine 100 mg IV QATH. There she developed hypernatremia and all her fluids were changed to 5% dextrose. She was shifted to the heat stroke unit and then to E ward. CNS examination was done in E ward, and her higher mental functions were normal. Motor, she did not have any deficits or sensory deficits. Her reflexes were however brisk. Her gait was not assessed, and she did not have any cerebellar signs. While in the ward, she was having persistent low-grade fever and tachycardia, and she had irrelevant talk. So the differentials considered at that point were cerebral venous thrombosis, a worsening of the Wernicke's encephalopathy precipitated by the 5% dextrose, or a thyroid storm. An MRI with a venogram was done, which did not show any features of CVT or Wernicke's encephalopathy, but her thiamine dose was increased to 500 mg IV QATH. TSH done showed was less than 0.008. The normal value in pregnancy is 0.1 to 2.5. Her free thyroid levels were also elevated for the normal levels in first trimester for pregnancy. Her beta HCG was 1,11,700. Her anti-TSH receptor and anti-thyroid antibodies were within normal limits. Because we had considered a thyroid storm at that point of time, we went back to her vitals in emergency and calculated a Burch wortofsky score. At that time it was 85, and while in the ward it was 65. More than 45 could be a thyroid storm. She was started on propylthiouracil 50 mg BD and propranolol 40 mg OD. The diagnostic dilemma we had was in the presence of a heat-related illness with a probable Wernicke's encephalopathy, differentials like thyroid storm which have similar clinical features, we couldn't differentiate what was due to what. The heat stroke, she fulfilled the heat stroke criteria for having more than 104 degree temperature, neurological deficits, and the ambient temperature outside. So finally we thought of an entity called gestational transient thyrotoxicosis, which presents with a low TSH, high free T4 and T3, and absence of thyroid antibodies. A study done in Singapore showed a prevalence of 11% in first trimester. This is due to the stimulatory effect of beta HCG on the TSH receptor, and it is associated with persistent vomiting and hyperemesis gravidarum. The clinical features include anxiety, tremor, heat intolerance, palpitations, weight loss or lack of weight gain, goiter, tachycardia, and hyperreflexia. The severity of hyperemesis correlates with the degree of hyperthyroidism and usually resolves by 18 to 19 weeks of gestation. The biochemical hyperthyroidism is associated with a beta HCG between 1 lakh to 5 lakh and clinical hyperthyroidism between more than 5 lakh. For our patient, at 15 weeks, the normal beta HCG is up to 2,54,000. So this actually falls within the biochemical hyperthyroidism falls within the normal limits also. The treatment recommendations are propyl thiouracil in the first trimester and, if indicated, methimazole afterwards, beta blockers to control the heart rate, and if very severe, a subtotal thyroidectomy, which can be done in the second trimester. The take-home message is, in the presence of heated illnesses, other diseases with similar presentation should not be missed.
You said she was severely emaciated, right?
Yes.
So what do you think was the cause of that?
Most probably she was not taking anything orally for the last 2 months.
So she had rapidly lost weight in the first 3 months? Or?
No.
Was there something pre-existing?
Maybe.
First of all, a very good diagnosis, but then her history had a clue. Just put the first slide. You said she had intermittent fever. In a heat stroke, you will not have intermittent fever. The fever does not, high temperature does not come down at all. So if that is true, you should have thought of something else at that particular point in time.
Any other questions or comments?